Hello, so this is my presentation on tamoxifen. My name is Alexandra de la Cruz, and the goal of this presentation is to learn about the mechanism of the specific drug called tamoxifen and how it is currently being used to treat cancer. Tamoxifen is a selective estrogen receptor modulator used to prevent breast cancer in women and treat breast cancer in women and men. So to start off with the mechanism of action of tamoxifen, it is known to have a dual mechanism of action. One of them being is to compete with 17B estradiol, also known as E2, at the receptor site and to block the promotional role of E2 in breast cancer. The second one is to bind DNA after metabolic activation and to initiate carcinogenesis. Tamoxifen was able to dramatically reduce the formation of E2 epoxide and measured by both the loss of the ability of E2 to inhibit nuclear RNA synthesis, and it is currently being used to treat breast cancer overall. So now to speak about the damage that it does to the cell cycle. Studies have shown that tamoxifen inhibits proliferation of the MCF7 breast cancer cells by invoking a transition delay very early in the G1 phase of the cell cycle. The tree-treated thymidine labeling index is markedly reduced by tamoxifen, and it indicates a reduction in the fraction of cells in the S phase. Flow cytometry of this mithramycin stained cell overall revealed that cells accumulate in the G1 phase with a concomitant depletion of the S and G2M phase cells with tamoxifen. Mapping of the G1 phase cells by morphology or prematurely condensed chromosomes demonstrated that tamoxifen treated cells accumulate early in the G1 phase. So the G1 phase is overall being heavy affected. So now to talk about it step by step and what's going on here. In order to determine the effects of tamoxifen on the distribution of MCF7 cells in other cell cycle phases, DNA histograms were obtained by flow cytometry of mithramycin stained cells. After 72 hours in a control medium, 72% of the cells were in the G1 as revealed by computer analysis, and 9% were in the G2M phases. Tamoxifen treatment resulted in a marked accumulation of cells in the G1 with a 92%. When experiments were carried out for longer time periods, which was around 6 days, cells exposed to tamoxifen remained in the G1, indicating that the block in the G1 phase was not temporary. It has been reported that serum-deprived or plateau phase normal cells accumulate in early G1 phase, whereas malignant or transformed cell population accumulates in the late G1. So that's exactly what's happening here. It's just overall showing you the activity and the inhibition of tamoxifen on the cell cycle distribution of MCF7 cells. So the interference and side effects and the overall history of tamoxifen is that although tamoxifen can induce apoptosis in breast cancer cells via the upregulation of pro-apoptotic factors, it can also promote uterine hyperplasia in some women. So therefore, tamoxifen as a multifunctional drug, but it could have different effects on cells based on the utilization of effective concentrations or the availability of specific cofactors. Some important facts about its history is that it was first known as a compound ICI 46474. Originally, it was going to be used as a contraceptive pill, and it was synthesized in 1962. Another fact about it is that it first was mainly used as a palliative treatment for advanced breast cancer. An important turning point in the journey of this drug is that when it went from an orphan drug to being one of the best-selling medicines in the 1980s, when the clinical trials showed that it was also useful as an adjuvant to surgery and chemotherapy in the early stages of the disease. So some cancer disparities that we see here is that Hispanic and Latino and Black African American women will have higher rates of cervical cancer than women of other racial or ethnic groups, along with Black and African American women having the highest rates of death from this disease. Despite having similar rates of breast cancer, Black and African American women are more likely than white women to die from this disease. So how can cancer disparities be solved in the U.S.? Some things that I came up with is by making healthcare resources more available to everyone and make healthcare more affordable in low-income communities. educating the general public more, funding research studies to define the biological and environmental differences in disease, improving tests and updating screening criteria for high-risk minority groups, and of course having support groups just for those people that really need it. And these are my references for all of the content. Thank you.